varied views there. So let's get our opening panel discussion underway. I'd like to invite Liz McAnulty, Trustee of the Patients Association, James Titcombe, Patient Safety Advisor from the Care Quality Commission, and Audrey Birt, Chair of the Health and Social Care Allowance Scotland, to come up and join me. Okay, so Liz, let me start with you. Now, you have experience in many different aspects. I mean, you are trained, I believe, as a nurse midwife. You're a qualified barrister. You've been involved in healthcare regulation, and now at the Patients Association. So you can approach the whole aspect of healthcare regulation from many different sides. Tell me a little bit about your background, say at the Nursing and Midwifery Council, and how that's informed where you are today.
Well, at the Nursing and Midwifery Council, I was primarily responsible for dealing with misconduct amongst nurses, and we received 4,000 to 5,000 referrals per year of nurses and midwives. And it made me realise that regulation is important, but by the time a nurse or a doctor gets to the fitness to practice stage in their career, the damage is done. And unfortunately, with regulators, as was the case with that regulator and with medical regulators the world over, less than 0.01% of the practitioners face misconduct allegations, but more than 50% of the budget is spent on dealing with that. The regulators, it's often forgotten that they have two other vitally important functions, and that is setting the standards for entry to the register, making sure the right people are recruited into medical schools, and maintenance on the register. Now, if regulators got those two aspects right, it may well prevent some of the problems arising. There will always be a need for fitness to practice function, but I believe, and I've learned through my experience, that is, the balance is wrong at the moment in terms of the emphasis on getting things right before patients are harmed.
And at the Patients Association now, do you think that patients are viewing this, are they generally cynical about the way in which the medical profession is regulated?
I think what patients are frustrated because it's not just the regulation. The thing is, you can have a gold standard regulatory system, but if that doctor is working within a system where it's poorly resourced, poor equipment, and most importantly, poor management structures, then that doctor is not able to function in the best interest of the patient. So I think that the regulators need to work more closely with the other cogs in the wheel of public protection to make sure that they all work together in the interests of the patients. So it's the doctors, the regulators, the National Health Service, the private healthcare structures to work together. It's no point in saying, in my club we've got this right. The patient is there and needs to be the centre of all of those institutions.
But do you think patients need to get involved, in a sense, at an earlier stage, in terms of? But shouldn't we just leave it to the professionals? I mean, patients, we'd all love that guy. They've never been to the doctor. I mean, yes. Most people wouldn't really want to know. Look under the bonnet.
Yes. Well, who is at the centre? If we are to pay more than lip service to the centrality of the patient in all of healthcare and regulation, the patient must be at the centre. That is what all doctors and other health professionals, that is who they are there to serve. And it is improving within the UK, but we still have a long way to go. For example, when I was at the Nursing and Midwifery Council in the late 90s, there were 60 council members and only 4 were patient representatives. Now, I think in most regulators in the UK, I don't know what other countries the balance is, but it's at least 50-50 patients and then professionals. But the patients should be involved at the setting of standards for entry. We know, for example, that the matters of most concern that we receive at the Patients Association, thousands and thousands of patients contact us every year, and their main concerns are poor competence on the part of their carers, doctors, nurses, others, poor communication skills, and poor attitude. Now, those are the issues which need to feed into the two front ends, the front aspects of regulation, entry to the profession and maintenance, to get those things right so that we do not have an undue amount of registrants being referred to the fitness to practice aspect.
The number of complaints, have they gone up?
They're going up every year. Now, part of that is to do with education of the public, and there's still a lot more work to be done on that. But one of the issues that I think that the General Medical Council and other regulators could do is know where the limits are to regulation. And unfortunately, we find that patients feel that the General Medical Council can deal with the poor food in wards and other issues sometimes. It's having clear videos like this one, other media messages for patients that they can discern. When I've got a complaint, I go to this organisation or that organisation. But one of the other difficulties, if you are a patient in a hospital and you're there for a week, you are going to encounter doctors, nurses, radiographers, physiotherapists, and so on. If you are very unfortunate and had a complaint about each one of those, you have to go to up to 9 different regulators within the United Kingdom alone, a very small country, really. So one of the things, and I know it is contentious, but I don't understand from the fitness to practice point of view, if you are assaulted by as a patient, it shouldn't really matter whether it's by a physiotherapist or a doctor or a nurse, but you have to choose which organisation to go to. Why is the fitness to practice element not a unified aspect of regulation? So yes, you need separate standards for entry for each profession. You need separate standards for maintenance. But fitness to practice is about poor performance, it's about poor communication, it's about sexual assault of patients, theft from patients. We need one regulator to deal with all of those type of allegations. The cost savings, I believe, when you add the millions and millions of pounds that are spent by UK health regulators on dealing with fitness to practice cases, first of all, it's done, the horse has already bolted, the damage is done. A lot of that resource could be saved and moved upstream into ensuring that the standards for entry and maintenance are not just set, but monitored, promoted, and that regulators work with patients and with other organisations to make it work.
Okay, well, I think we'll hear examples of systems more like that as the conference goes on, and we'll put those suggestions to the regulators here. Audrey, we'll come back to you a little bit later. James Titcombe, you're now Patient Safety Advisor at the Care Quality Commission. Right, yeah. But James, you've got a personal and very tragic experience of the when healthcare goes wrong.
Absolutely,
can you tell me about that?
Yeah, so my background is nuclear industry. I was a project manager working up at Sellafield, so life was kind of ticking over quite nicely for me. And then in 2008, we had our second child, Joshua, at Furness General Hospital in Cumbria, part of Morecambe Bay Trust. And shortly after Joshua's birth, my wife collapsed with an infection, and she was given antibiotics and treated. But we asked about Joshua, you know, if my wife has an infection, doesn't he need treatment? And we were just told, no, he's absolutely fine. And all our concerns were brushed away, really. Your son's fine, it's your wife you need to worry about. And over the next 24 hours, there were all kinds of signs that he really wasn't very well that we raised, and they were ignored. And sadly, Joshua actually collapsed as a consequence of sepsis at 24 hours of age. He then lived for 9 days of intensive care in various organisations. He went to Manchester and then Newcastle, and then died in really horrific circumstances at 9 days old as a consequence of this infection that could have been easily treated. And yeah, that's had a profound, as you can imagine, a profound impact on our lives.
Now, it's one thing having a terrible personal tragedy like that, but when it came to that in the investigation, you've come from the nuclear industry.
Yes. Yeah.
There's no room for second chances there. What was the investigation like?
And this is the bit that really shocked me because, you know, a rusty bolt in the nuclear industry that shouldn't be there would trigger a kind of robust investigation, and quite rightly. I just could not get my head around the response. We waited months and months, and we had a very poor incident report that was about 7 pages long. It was broad, it left so many questions unanswered. But then where do you take that from that point? And we went everywhere we could go. So the coroner wouldn't investigate. We went to the Parliamentary and Health Service Ombudsman, and they didn't investigate. Everywhere we went to, we couldn't get an investigation. And actually, the Care Quality Commission, who I work with now, their role in what happened at that maternity unit was criticised last year in a big report, and they were found not to have done what they should have done. They inspected the unit with staff that weren't qualified in, hadn't got the experience in midwifery care, and actually gave the unit a clean bill of health when there were actually significant risks to mums and babies. So my personal experience is of catastrophic failure, but then perhaps an even more catastrophic failure in the way organisations responded to it, including, of course, regulation.
So tell me now how that is informing what you're doing now at the CQC.
Absolutely. When this happened, and the people might remember the summer of last year, there was a big scandal in the news about CQC's role in Morecambe Bay. I met the chief executive and the chair of CQC, and they came up, and their response wasn't defensive. Their response was, actually, we've really got this wrong, and we've got to fundamentally change what we're doing. So CQC are right in the middle at the moment of a transformation programme. They're changing the entire approach to inspection. So we don't use generic inspectors anymore. We have specialist inspectors in each sector, as you'd expect. We take experts by experience with us, so patients who've had an experience of a service. There's much greater focus. I think if you look at the story of mid-staffs and you speak to Julie Bailey and people like that, they would say, to know what was going on, all you had to do was speak to the patients. Look at the complaints people were making. I think that's a fundamental change in terms of what CQC are doing at the moment. Much more focus on looking at the complaints people make, speaking to patients, listening events. So I think, yeah, everything about the way we regulate at the moment is in the midst of transition.
And I think you've done a bit of survey work with the Patients Association.
Absolutely. Well, this theme about listening to people, so the importance, I think it's been described as complaints are gold dust. Every concern or complaint is an opportunity to learn. And we really believe that. So complaints to CQC, one aspect of that, they tell us about where there might be risks to services, so we need to know. But the other aspect, actually, is how well are providers themselves listening and responding to complaints from people. So we did a great bit of work with the Patients Association where we took their standards in complaints handling and we did an approach of looking at how well providers listen to complaints and respond. And that work's kind of evolved. We did a trial of 11 trusts. We found some quite shocking things, actually. So I think over half the people we surveyed felt that they hadn't been given full honesty in the response from the organisation. So this gives you an idea of the improvement we need to see across the system. But that approach is now being embedded into every inspection we do. So at every inspection now we will look at how well providers themselves are responding to concerns and complaints from members of the public.
Great. Okay, James, thank you very much for that. Now, our final panellist, Audrey Birt. Now, Audrey, you're Chair of the Health and Social Care Alliance in Scotland. Can you tell me a bit about that body?
Yes, the Health and Social Care Alliance is an alliance of charities, both large and small, across Scotland. We do have a number of associate members as well, where from healthcare and social care backgrounds, and some individuals. And essentially I worked with some others to set it up a number of years ago when we felt that the voice of people living, particularly with long-term conditions, wasn't shaping policy enough. And that was, I was a director of a large charity in Scotland at the time. So it's been a passion of mine to ensure that people's voices are there to help shape policy and practice.
Now, you trained as a nurse,
yes,
and you were telling me that you have some personal experience, as we all do, except for that one man there, of the quality of healthcare with a diagnosis of breast cancer.
Yes, I was first diagnosed with breast cancer in my 30s, and I was still working as a nurse then. Probably what shaped my response to that was also my father was being treated for terminal cancer at the same time. And after he died, in uninformed and largely uncared for, at the same time I was being treated with breast cancer, I did complain about his treatment, and was met with huge defence by the people who investigated the complaint. I won't go into all the detail, but what struck me was how unwilling they were to listen. And so it took me from working initially as a nurse, then into health service redesign, to try and make a difference. But then I thought working outside of the health service itself was maybe the best way to make a difference, which is when I went in to work in the third sector. Yeah.
Now, Audrey, you had another diagnosis more recently of breast cancer. What has changed in the intervening years about the way in which you were treated and the way in which your voice was heard?
Yes. And I think breast cancer, and at the time I was diagnosed, more recently I was Director of Breakthrough Breast Cancer in Scotland. So I was in a sort of a multi position, if you like, which in itself was challenging. I started blogging at the time so that I could help people understand how that felt. I think from my point of view, I was much more listened to as a person, and I would contend that the way we make safe practice, yes, we have to regulate, absolutely, but the way we make safe practice is putting the person at the centre of that practice and really listening to them. And I found that this time round that I actually declined some cancer treatment because I'm a well-informed patient, and I only agree to being a patient when I'm actually in active healthcare treatment. The rest of the time I'm someone living with more than one condition. But I was informed, and I had early stage disease and decided to decline treatment. And I was supported to do that by the consultant, who said to me, it's our role now not to tell you what to do, but to listen to what's right for you and support you to do that. And I thought he embodied person-centred care for me. And that is the way I feel to drive safe practice in the future. And not just in a one-to-one, but to have people sitting around the table, as you were saying, not just in organisations like GMC and CQC, and in Scotland it would be Healthcare Improvement Scotland. What we need to do is plan care alongside people with experience of that care. And I think we're doing that more and more in Scotland, and we're starting to see it change. But if people are accountable to those they serve, then that's when you see the real shifts in behaviour, an understanding of the impact of poor treatment, I think. So I think there's a huge amount to be learned from complaints, and I don't think we always do that. But there's a huge amount to listen to what matters to people, and I think, you know, your situation, if someone had listened to you.
Absolutely.
you know, your child would still be here. And that is so often part of the story. It's so often part of the story. It's about being listened to. And to see the person, not just the condition or not the fact that they're patients. Because after all, as you said yourself, Fergus, we're all patients. People often ask me to speak about what matters to patients, and I'll say, well, it's what matters to you.
Well, let me open up to the three of you now. I mean, we're here to discuss medical regulation and healthcare regulation, but do patients really need to get involved in that? Hopefully, the vast majority, will never have an appalling experience like we've heard this morning. But do they really need to know about it as long as it's working well? What do you think, James?
I think, you know, the lesson from recent years is actually it is incredibly beneficial for patients to be involved and have a voice in regulation. And one of the reasons, of course, is patients' perspectives, reaching out for those views can really tell you about whether things are working in the way they should. So if a regulator has a remit to have a proper overview and an understanding of people's experience, then I think reaching out more to the views of patients is massively important.
A lot of doctors, I can hear silently a lot of doctors saying patients can be a real pain. And really, you know, they don't understand how medicine works, or they've looked something up on the internet, and you know, they're swamped with regulation. So there is a danger. You wouldn't want the patients to sort of drive the medical regulation bus, would you?
There's a balance, isn't there? But I think the balance is the perspective, and understanding the experience is important. You know, I really do think that.
Okay, Liz?
I think it would be very sad if we wanted all members of the public to be aware of the machinations of medical or other healthcare regulation. But when they want to know about it, then they need to be able to access that information clearly and in a way that meets their particular needs.
What do you think, Audrey?
One of the things through the Health and Social Care Alliance we did recently was try to influence a bill going through Scottish Parliament to have one point of complaints so that it simplified it. We actually weren't successful in that, but I think what we have done is open up some of that discussion about it. So I absolutely agree, if we're only focused on regulation and complaint, we've lost. But on the other hand, when people do have very real issues, they need to know how to approach that. And I think, you know, when many of the complaints are around communication and attitudes and so on, then learning alongside patients, in this situation, that's probably the right word, then can help to prevent those things. And I think that's where we have a very important role.
And I presume you're sympathetic with Liz's proposal then to have maybe a one-stop shop.
Absolutely.
For when things go wrong.
Yeah.
Would you like to see that across all healthcare systems?
Yes, I would. And I think also a quicker process. I know from experience of hearing doctors who've been through regulatory systems that it's very lengthy and very destructive to people. And I think that's not a good outcome for anyone.
James, did you find it easy to complain? I know the answer to that question.
No, it was incredibly complex, and as has been pointed out, there are so many different organisations, so you find yourself literally having to write to a dozen different organisations, and that's confusing, it's complex, there's duplication. So this idea of a one place to go, I think is very, very powerful.
It might be easier for the patients, but it wouldn't necessarily be better though for the doctors. Looking at it from each healthcare professional, they would presumably want to be judged by their peers under the system that they have set up. I mean, that would be difficult to have a one shoe fits or one size fits all.
Well, panels who consider the cases, you can have a legal person who understands the very major complexities around the fitness to practice procedures. But then you can have a patient or member of the public and a doctor or a nurse or a physiotherapist, whoever the professional is, and of course expert witnesses, so that the panel can hear that. So again, it's making sure that it's there in the interest of patient protection and public protection.
Really important point. I mean, we're going to have a statutory duty of candour soon. So there will be a legal requirement for any errors that have resulted in harm to come forward. Now, I think it's really important, talking about fitness to practice, that actually we recognise that medical professionals will make mistakes, and in the vast majority of cases, they need support and training, and the culture needs to be more aligned to that. But actually, where we need zero tolerance and where fitness to practice needs to really take action is where there's dishonesty or reckless behaviour.
Okay. Yes?
I think one of the things I mentioned that I worked in healthcare redesign, and James will know this from the nuclear industry as well. It's often where there are catastrophic failures, there are systemic failures, and sometimes we can oversimplify it being about one person's fault. That's rarely the case. Yes. And there may be individuals who should be held accountable for it, but also we need to look at systemic failures and improve the culture around that, because only focusing on individuals will not make patients safer.
A really important point, and one of the things in the nuclear industry was this expression human factors, which is about really understanding human behaviour. Big absence in healthcare regulation. I think that's something that needs to be thought about. So actually considering the science of human behaviour, especially in fitness to practice cases.
Great, well thank you. I'm going to bring in the next three panellists to put some of those points you've raised to them, if you would stay where you are. Dr. John Thomas, who's board chair of the Federation of State Medical Boards in the United States. Welcome, John. Philip Pigou, who's outgoing chair of IAMRA and chief executive of the Medical Council of New Zealand. And Dr. Eli Kwasi Atikpui, who's registrar of the Medical and Dental Council of Ghana. Welcome, gentlemen. John, just get your immediate reaction. Obviously, you come from a very different system, as you all do from here, but does that, what you've heard, remind you of the sort of opinions you get from patients, Mac, in the States?
Oh, absolutely. In the States, we have it's interesting hearing how the system's described. In the States, it's not our federal government that regulates the practice of medicine, it's each individual state. And I've said it many times that think of us as 50 different countries that actually share the same currency and share a language, but each state does it in their own way. Now, there's similarities, but in many ways, in listening to this, we have the same issues, but I feel the responsiveness is a little easier because the states aren't dealing with the large number of population of patients or physicians. And so we have some states, the largest state is California with 38 million citizens. And the smallest state would be Wyoming that has 500,000 citizens. And so there is not a one-size-fits-all. And so in some of the smaller states, they can be much more responsive to the needs of their citizens. So we don't hear the level of, say, like the shipment inquiry. Something like that has never really, there's never been anything like that in the US. We've had bad actors, but it might be from state to state and they get sort of taken out of practice pretty quickly. So I would say we have the same issues, but I think the responsiveness sometimes can be a bit faster.
Doesn't that make it even more complex for patients if they move from one state to another about, if something goes wrong, how do they get effective redress?
Well, our Constitution basically gives the states, each individual state has police power, which means to protect the health, safety, and welfare of the citizen. So that falls to the state. So a citizen in a state, if they have issues with a physician, they actually will go to the state, which is much more local. And so we feel that's a much stronger, much more responsive, because we fear that if the federal government in the U.S. were to take on this role, a patient in any one of the states calling the federal government for redress would have to navigate a very complex bureaucracy, whereas at a state level, state by state, the states can be much more reactive, much more responsive because they're dealing with their own citizens. So if this person is moving from state to state, well, then they'd have to seek redress in the state that they had the medical care.
The caricature of, one of the many caricatures of healthcare in the United States is that this concept of defensive medicine, because there are a lot of complaints, and lawyers are involved. I mean, is it a more legalistic system than say in the United Kingdom?
No question. There is a perception by physicians. It's a perception that they're prone to lawsuits. The fact that that isn't really true, because most physicians prevail in most lawsuits. But the perception of physician is that it's very legalistic. And so one of the issues that drive lawsuits is, I forget which one of you said it, but it's when a patient feels that they haven't been, when there hasn't been proper disclosure, then patients will seek redress in the legal system. And they'll often seek out a malpractice lawsuit, which most physicians fear, because that obviously in the U.S. in some places there is no limitation on there can be massive financial penalties involved with some of those lawsuits. So that's the redress when a patient feels that it hasn't been dealt with in an appropriate fashion in the States.
And are patients involved in the regulation, or is it sort of left to the state and patients go to them when things go wrong, or is there real patient involvement?
Oh, absolutely. I mean, in the U.S., the Federation of State Medical Boards, while it doesn't have any legal authority to tell states what to do, we can actually help states with best practice. And we have a Model Medical Practice Act that most states adopt much of. I mean, the states don't have to use the entire Medical Practice Act, but the Model Act, many states use it. And in the Model Medical Practice Act, there's a recommendation for significant patient influence in being on the boards of medical practice. So most states in the Union have significant patient representation on the medical board itself. So we really seek a public input. And we want a public that's not a public that's actually engaged in the practice of medicine or family members in the practice of medicine, but real public members who actually experience the medical system. So we would love to have you on the Minnesota Board of Medical Practice should you ever like decide to move to Minnesota, because this is the type of input that we really would like to have.
Okay, John, thank you very much. So Philip, if I turn to you, the comments you've heard here today from about patient involvement, how does that apply in New Zealand?
I think there's been a massive change in the last 30 years, and probably longer. In 1986, my daughter died. We took her to hospital at around midday. She'd collapsed at home. And the paediatrician, well, the junior doctor saw her first, and the nurses, and they said to the paediatrician, you need to come and see this baby girl. And the paediatrician took 6 hours to come and see my daughter, saying it's colic. When he finally did come, he realised that it wasn't colic, and she was rushed to surgery but died shortly after. And halfway through the surgery, obviously the paediatrician wasn't doing the surgery, the surgeon was doing that. The paediatrician came out and said to me and my wife, she's obviously suffered a major trauma. Now tell us what happened. And it wasn't said once. It was said several times, because initially I didn't actually even understand what he was saying. When I finally did understand what he was saying, I sort of obviously got more upset. But I think I was a young lawyer at the time, 29. I didn't even know how to complain in New Zealand at the time. And I think New Zealand's changed a lot in terms of the establishment of the Health and Disability Commissioner, and our previous one is sitting in the second row, Ron Patterson, who has done an absolutely amazing job in New Zealand regulation in terms of promoting patient rights. And I pick up on Liz's point earlier around the need to, if something does go wrong, have a complaint system that actually supports the patient or the patient's family, and not actually the practitioner. So in the New Zealand context, if a complaint is made, now it goes to the Health and Disability Commissioner, and they would look at all of the professionals involved in the care of that situation, of that patient, plus any of the systemic issues. The medical council or the nursing council or whoever the regulator is, in addition to the HTC, would look at the competence issues around the doctor if there were competence issues. Now, I think in terms of that example I gave, I think the standards that have been established in New Zealand have really promoted much better patient interaction by doctors. There's a lot more emphasis on patient rights, and they are rights in a statutory sense. So they do have corresponding duties on the doctor, and the doctor is held to account to those duties. So I think also now, back in 1986, those issues might have been seen more as a competence issue. I would argue that now some of those issues would be seen clearly as a conduct issue, and I think the way we would deal with them in New Zealand changes. So competence issue would be looked at very much in a rehabilitative, re-education approach, while also maybe putting some restraints around the doctor to ensure the doctor is not harming the public, so supervision and various other things. Conduct would be looked at very much in a disciplinary sense, as well as the conditions, the suspension, possibly supervision, various other options as well.
Eli, thank you, Philip. Eli, how strong is the voice of the patient in Ghana?
It's quite strong because the complaints are generally made by the patient. And apparently, in the course of dealing with a complaint, the patients are really invited to the Penal Cases Committee, which is the first investigatory committee of the council. And then, if the case is referred to the disciplinary committee as well, patients really come in, or the complainants come in as witnesses. And apparently, they provide the information, even though at specific levels, the council takes up the responsibility of ensuring that the case is dealt with. But again, the case cannot continue in the absence of the complainant, who will serve as a star witness at the disciplinary committee level. So generally, I think that they play a very strong role in dealing with cases of fitness to practice.
Now, I've reported several times from Ghana, doing stories about malaria and other developing world disease threats, and obviously West Africa's got some very difficult ones at the moment. All healthcare systems are hard-pressed for cash,
Exactly.
but Ghana's would be very hard-pressed. Is there the money, are there the resources to adequately both regulate healthcare and prevent problems happening at an earlier stage?
Well, I think you've just stated it. You know, most jurisdictions south of Sub-Saharan Africa really don't have the resources. And it's the same thing that happens with the regulators. I mean, most of us are supported by government. But again, if you look at the inflows from government, it's quite minimal. And therefore, we are really constrained with resources, availability of resources, which apparently also affects, you know, the length of delivery of justice. Yeah.
Do patients, Eli, do they understand what the regulator does, or is it a very confusing system for them if something does go wrong?
Generally, they don't understand. Because a complaint is made to the regulator, the first thing the patient is looking for is compensation. Apparently, regulators don't provide compensation. They are interested in the conduct or the fitness to practice of the practitioner. It takes a lot of time for us to really explain issues to them, to tell them that, well, you've made a complaint to the Medical and Dental Council. We are interested in ensuring that a similar thing does not happen again. and that we really don't deal with compensation. Now, in the event that you'd want any form of compensation, then you need to go seek redress at the courts. Yeah. So there is a limited, or there is a lot of confusion among the patients.
Let me ask the three of you, gentlemen, what practical suggestions do you have to improving the way in which the regulators can work with patients and the public? Start with you, John.
Well, I think it gets to character of harms. Typically we have processes that we focus on, and I think the important thing is to collaboration. I know in the U.S. we collaborate across organizations with the public, with accrediting bodies, accreditors of undergraduate medical education, accreditors of graduate medical education, our organizations that do assessment and testing, with patient organizations. It's those types of collaborations, I think, that are really important in order to solve some of these issues. Back in 2001, the Institute of Medicine, which was a government-sponsored organization, did a study of safety and came out with a scathing report of safety issues in hospitals and in the healthcare system. And that really spurred us to look at safety as a country, basically, and to listen to patients and put patients in the center. Now, we haven't moved the needle a great deal. It's only been 11 years. The public would say that's time. That's more than enough time, but as you know, government takes a while to move. So, but we're really starting to take this to heart. And I think in another 5 to 10 years, you're going to start to see some significant improvement in patient safety initiatives with significant input from the public.
Philip?
I think the first thing we have to do is actually hold up a mirror to ourselves as regulators and ask two questions. The first one is, are we actually hearing the voice of the public? And the second one is, as the public watchdog, are we adequately speaking on behalf of the public? And I think there's two further categories around that. So there's the fitness to practice so-called downstream regulation, which I quite like that the rhetoric the GMC use around that. So when we're looking at a doctor's performance and assessing that, or looking at a doctor's conduct and investigating that, the patient voice is actually important in both of those scenarios, and I think in slightly different ways. So on the conduct side, I think it's important that the patient actually is part of the information gathering by the investigators. Really important in terms of the patient also getting feedback about how the investigator has looked at it and what they're doing. On the performance side, the competence side, I think it's very important that a wide range of multi-source and patient feedback is gathered to actually help the regulator understand whether the doctor is performing at the required level. So that's the downstream side. On the upstream side, which is around using the term revalidation in the UK, or what we call recertification in New Zealand, or setting the standards for medical education in New Zealand, the standards of good medical practice and the like. It's a more, I guess, policy approach, more strategic approach, getting as much patient involvement through public surveys that we've done.
Let me jump in there and ask you, actually, is the role of patients actually changing now? Not just with regulation, but in their relationship to doctors?
Yes.
Yeah.
John, do you want to
Absolutely. I mean, it's interesting. Someone said that doctors find it a pain that patients look at the internet. Well, personally, I tell my patients, thank you. I got something to work with now. I mean, I can actually teach someone because you're interested. I think patients in the future are going to be more engaged. I see the younger, I've had many younger patients come in to me and tell me what their diagnosis was. And the first few times I kind of chuckled and says, well, that's nice that you're looking on the internet, but let me really inform you. They were right? They're both in their 20s. And so, I think patients are going to be more engaged. They're going to have more tools. They're going to want more transparency. They're going to want more information. I have patients who come to see me and they say, I've checked you out online. Now, I don't know what that means. I'm afraid to ask. But clearly they're getting, and some patients have actually told me my CV. Oh, you trained at Mayo, or you were in this position or that position. So I think patients are going to be much more armed to be able to do some of these things to really hold us accountable, and I think that's good.
Eli, what do you think?
Yeah, I think that there's a lot of rule from the patients because apparently the patients make the complaints and they expect or they have some expectations, and the issues are whether or not these expectations are being met. Now it comes to that of the practitioners as well. Now the other issue is how competent is that practitioner and what is the role of that practitioner. So we are in a balancing situation. Where are we going? Are we going towards the practitioner or the patient? Apparently, the council is set up basically to protect the patient. So invariably, the practitioners are complaining. The patients are also complaining somehow because their expectations are not being met. So I think that along the line, we should ensure that when complaints are made, information goes to the practitioner and also the patient, telling them possible expectations and all that. They go in there, get onto the website of council, and they expect that either the practitioner's name is erased or the practitioner is sanctioned, even though, the practitioner might not really be, the cause of whatever professional misconduct or whatever. There were issues of system failures, and I think that in our part of the world, most often, as we talk about system failures, practitioners may be roped in there that you have a case of postpartum hemorrhage, there's no blood, the patient expires, and the practitioner is dragged to the council. How do you really reconcile this situation with the practitioner's competence and also the system failure? So I think that as we move along, there should be issues of ensuring that the patients are looked at, having some of their expectations met if possible, and that the practitioner should also be guided accordingly.
So I think we'd all agree that patients have higher expectations than ever before, but do you think doctors are learning from that? Are they responding appropriately? What more needs to be done, Philip?
Yeah, I do think there has been a significant shift in that sense, and I think it's been brought about by a whole range of societal factors, including the major sentinel events that have occurred in the UK and New Zealand, I'm sure in various other countries as well. The issue is, as a regulator, we shouldn't wait for sentinel events to make change for improvement. Our focus as a regulator should always be first and foremost on quality improvement and the highest standards for the profession in terms of openness and effectiveness of medical practice.
Okay, great. Well, I'm going to open it up to the audience now. We've got, I think, about 4 mics in the room. So if you'd raise your hand or indeed stand up, and we'll bring it to you. And if you could just tell us where you're from, yes, the gentleman there, and tell me who you'd like the question put to.
I'm Steve Sealing with St. George's University. To the entire panel, great session. The points that have been made are indisputable, beyond debate. But let's have an adult conversation about resources, because the things you're talking about cost money. They're not cheap. I know, Dr. Thomas, even in the U.S., among the 50 boards, more than 50 boards, great variation in terms of the resources available. So let's have a real conversation about what can be done, politically and otherwise, to make sure that the boards, the regulators, have the resources to do what we all agree is appropriate.
Okay, who'd like to take that? Resources in a cash-limited system.
In the U.S., there is variation, and again, all boards aren't created equal. In the U.S., most of the activity of the boards are done through licensing fees, right? So that's the lifeblood of most boards. Many states collect those fees, and sometimes in times of economic distress, the wisdom of our legislators sweeps that money into the general fund and takes away from the medical board. When there's an issue, they complain to the medical board, why aren't you doing the work of protecting the public? So there's always that, there's going to always be that issue.
But who's paying those fees?
The physicians. It's the physician licensing fees. And so many people believe that physician regulation comes out of the general tax funds of many states, but it's actually the licensing fees. And the fees in the U.S. are not that expensive. The range is from $60 US to about $500 US for relicensure, which isn't a great deal. So many physicians who sit on these boards and public members who sit on these boards see it as a public service. They're not paid very much, nominal, and they spend a great deal of time doing this work. So the wonderful thing is you have a great, there's an incredible sense of pride in the folks who do this work and dedication. And they do it on a really reduced significant budget, or on a small budget.
Eli, what about, well, you've said how difficult funding is for you.
Exactly. I think that, like he said, Tom said, 98% of what council does is from the licensing fees. And along the line, sometimes government will promise that submit a budget, we're going to support a budget, and that support doesn't come. Now, if you look at the value or the rates that are paid for licensing, they are quite minimal. And if you are depending on your output to really look at or protecting the patient, and you're using 98% of your budget coming from the fees, then you would have noted that without any support from government, you might not be able to achieve much. And I think that governments have set up their regulators. They need to support their regulators to ensure that their mandate is achieved.
Well, maybe we could save some money if we had a unified system. What about our patient panel here? What do you think?
I think I'd make one point, and that's it's worth reflecting on the cost of harm in healthcare. So in the UK, I think last year £1.2 billion spent in litigation. I think 6,000 avoidable deaths, I think they're statistically a year. So, you know, CQC's annual cost, I think about 120 million, very small percentage of the harm that's caused. I think you have to bear that in mind when we're talking about cost.
Audrey?
I think we have to remember that some of the recommendations we were making was, yes, one point of entry for complaints, but also shifting the focus and saying that if you're working differently and you're listening and you're responding more to feedback, then there will be less complaints. So actually working differently, changing your communication systems, listening more to feedback should shift things. And it's very similar to the arguments about healthcare that that often if you're looking at person-centred care, people worry that it will actually cost more, and indeed it generally costs less, and that there's lots of evidence to back that up. So I think, you know, it's about doing things differently. It's not always about cost. And I think we should be careful not to use cost as a reason not for against change.
Okay, let's go to another question. The lady at the back there.
Hello, my name's Marilyn Walton from Australia. I'd like to ask the panel their views about who they think these public, patient or community members are in regulation. Because we know the most important decision a regulator can do is not investigate a matter. And I know that many community members are involved in committees that determine these factors. I've also noticed an increasing professionalisation of community members. They're either lawyers or health professionals from other disciplines. My understanding of what the statute's intended by community is the person in the street. What would their views be in relation to what they would expect of a professional? Can the panel give us some views whether where they come from has criteria of who can be a public member or not, and whether they think we should go down this pathway of professionalisation of our community members?
Liz, let me ask you about that, because I mean you've got almost the sort of perfect background here, but in a sense, should we have people who are, if you like, brackets, ordinary patients, or people with a wealth of experience like yourself?
Well, I think that as someone mentioned earlier, every one of us in this room is either a patient or a potential patient. Whether we are ill, we need the assistance and the contact with health professionals, whether it's the dentist, the optician, whoever. And so we deserve to be treated with respect by competent, caring individuals who will communicate adequately with us. So I really don't think that you have to have had the tragic experience which my colleague panelists here have had to understand, and very often from the inside, if you have worked in regulation, that is where I have learned about how bad regulation can be. I've also seen how good it can be, but you know, anyone going into any organization as complex as a regulatory body, after a short while you begin to see where the gaps are, and I think then you're in a position to strive to improve things. But on the other hand, there is nothing more powerful than the stories of my colleagues here in bringing it home to everyone, how important it is that doctors, in this case, do regulate in the public interest, and that nobody gets up in the morning, no doctor I'm quite sure gets up in the morning with the odd exception and says, I'm going to go into work today and harm patients. The overwhelming majority want to go in and do a really good job. The role of the medical regulator is to facilitate them, along with other key stakeholders, but to facilitate those doctors to do the best job that they can. And so whilst I can see tremendous benefits from having real patients, I don't think it's a necessary condition for involvement.
Audrey.
I think there's several answers to this, and sometimes that talk of professionalisation of patients, or sometimes you hear people referred to as the usual suspects, is a way to perhaps not value input that people have. I am a real patient as well as somebody who has a degree in nursing, a master's in public health, and many other qualifications too. And I think some of what that gives me is a confidence to want to contribute. But that in itself is not what I think is all that's on offer. I mean, I speak on behalf here also of an organisation who consults regularly with its membership and those it serves, so that when I speak on behalf of people, I'm speaking on behalf of a large representative group. But also I think there's a huge amount of feedback out there, and I'm someone who's sort of taken to social media in later life, and I saw something recently, and it was a sign up in a general practice somewhere in the UK that said, please would patients not put any information about the practice on Twitter or Facebook, because they would not, that would be thought severely of. And I thought, here are people who are not living in the real world. Social media is fabulous feedback for us, and there are organisations like Patient Opinion here in the UK and in Australia, I believe, who can give us absolutely excellent feedback in real time for people who are having an experience. And let's remember that often that's very positive feedback. We need to know what we're doing well as well. So let's make sure that there isn't just one way to get feedback into a system to improve it, but also to respect that those people who are more experienced in giving feedback are often the ones who will sit round tables with you, and make your systems such that it means ordinary people, whoever they are, because we're all ordinary people, can feed into this. Because in my experience, sometimes being the token patient, or in the past being the token nurse even, having a voice in a system is very difficult. No wonder other people don't want to get involved.
Okay, Audrey, thank you. Our next question, gentleman there, please. Yeah.
Hi, I'm Andrew Smith from KPMG's Healthcare Regulation Team. Liz, you mentioned regulators needing to look at sometimes the system rather than the individual. And I suppose my question is, how far away do you think some of the regulators are from looking at the system as opposed to the individual, and how would that sit with patients? And flowing on from that, how effective do you think regulators are at looking at the leadership of organisations and looking at what's maybe working very well, and then also identifying potential failures in leadership before it becomes a
Liz.
Thank you. Well, I think rather than the regulator looking at the system directly, what I intended to get across is that the medical regulators need to work with organisations like the CQC, the National Health Service, at local levels, etc., to work with them to make sure that if the doctors are prepared, educated, trained, etc., and ready to perform to a high standard, the other people have to play their part in making sure that there are sufficient resources and equipment and other personnel to make sure that there is a good standard of patient care. But, you know, I'm not naive. Resources, that is a major issue. But unfortunately, and I see it on a regular basis and I hear it from patients, there is still a great deal of waste within our systems, whether they're regulatory, National Health Service, or other. And there is a great deal of work to be done in making our systems more efficient and therefore more effective.
Okay. Yes, John.
Yeah, I was going to respond. In the U.S., you know, often the states, there's the state medical boards, and then there's the state nursing board, and then there's the state hospital association, and these are all done in statute. So it's difficult for us to have those sort of conversations across disciplines. What we've done at the Federation of State Medical Boards is actually reach out to the National Council of State Boards of Nursing and the National Association of Boards of Pharmacy, at least at the highest level, to start talking about really how do we, as leadership, can get the states to actually start to talk about systems-based practice and how we act and behave in these settings. But I agree, it's a thing that we're all looking towards, this idea of a team-based care, and how to get there. It's going to be a difficult journey.
Yes.
Just to pick up on leadership, you know, fundamental to the systems regulator, what CQC do is a framework of looking at how well led an organisation is. We've done work with independent organisations to help us develop that framework, but we look at 5 key questions. So it's responsive. Is the organisation responsive? Is it safe? Is it effective? Is it caring? And is it well led? And interesting, what we've found is that the trusts that are well led, the correlation between being well led and an overall rating of good is very, very strong. It's an absolute indicator of how well overall an organisation's.
Okay, let's go to our next question. There's a gentleman there.
Is it working?
Yes, it is.
Thank you very much. I was encouraged really by some remarks made by the panel. Initially, I was not planning to take the floor. The question I am going to raise is, I am not from any particular organization, and my card says retiree, which is true. That's what it says. I'm from Somaliland, not Somalia, they are so different countries now, which has been in existence for the last 23 years, not recognized, but is still there in the Horn of Africa. A small group of doctors from Somaliland last year formed a small group for health professional regulations. Because of limited resources, both in manpower and other resources, we said that this group will cover all the health professions, from the community health worker to the doctor, all the way down. They will register and license all these health professions. By the way, we don't use even medical, we use health, because we thought it would be a bit more comprehensive and it include everyone, from the sanitarian to the neurosurgeon. They will also accredit all the health facilities, and they will accredit all the health training institutions. So anything to do with health, that small group will be responsible for that. And we also try as much as possible to be as much as possible free from the government, to be an independent organization, or we call it a commission. And my question is, if there's anyone with experience in this sort of thing, because I think one of our panel mentioned about the problem of having so many different groups dealing with different regulatory bodies in the profession. So if there's any experience in that field, which I don't know how it will fan in the future, but some people tell me that it's too ambitious to have just one group dealing with the whole thing. But we are sticking to that now. We don't know what will happen in the future. So if there's any experience in that field, because our moderator also mentioned that when you leave this place, you may have some useful information to take away back wherever you go. Thank you very much.
Eli.
Yeah, it isn't an experience per se, but the question I would want to ask is, the small group that has been formed, is it backed by law? Because all regulators, their activity, the mandate, is backed by law. If that small group, the activities, or the small group formation has a mandate backed by law, then that is fine. But again, without any legal provision, then you are just swimming in the deep ocean, which might end you a lot more problems than the good that you intend to do with the formation of that particular group.
Anyone else like to comment? Yes.
I think I would just like to say that in terms of you know, what you've heard from those of us representing the patient groups, that a simple process that looks at the whole system has to be a good thing. I mean, most people complain because they want to feel heard and they want to make sure it doesn't happen to anyone else. These are the key things that people complain for. And a system that is simplified and robust, and I think the legal aspects, of course, are important to make it robust. But a simplifying whole system approach, I think, is something, it may be difficult, but you sound like someone who's up for a challenge, so I would encourage you.
Okay. Well, thank you for all your questions on this session. I'm going to bring it to a close now. I'd like to thank all of our panelists. Really fascinating discussion. Just stay there for